Good evening and welcome all. Thanks for joining the Consultant Forum meeting this evening. A research-focused meeting this evening in terms of the Biomedical Research Campus here. What I'm going to do is hand over now to Miles Parks, Professor Miles Parks, a consultant gastroenterologist, who's going to run the meeting this evening and introduce our speakers. And there may well be some time for questions at the end. Miles, thank you very much for taking this on, and over to you.
Yes, thanks, Justin, and thanks everybody for joining us. Particular thanks to our speakers, obviously, who are going to be giving you a window on different aspects of the BRC shortly. I'm just going to give you a very brief overview of the BRC and what it is and what it's designed to do and deliver before we hand over to respectively Richard Gilbertson, Charlotte Summers and Raj Jenner, who are each individually then going to talk to their specific aspects, if that's okay. I'm hoping the technology will work okay. And let me just plunge in and just see whether I can make this work well. Hold on a minute. Are you on full screen there? Good. Okay. I'm taking a thumbs up as a good sign. Thank you, Justin. I've been the director of the BRC for a couple of years or so now. And I do confess that when I first took it on, I was a bit unsure actually what the BRC is. So for anybody on this Zoom call who's not sure what the BRC is, you're entirely forgiven because it's taken me a while to sort of piece it together. So I thought it would be helpful just to briefly introduce what the BRC is and does. The BRC is basically in existence, funded by the NIHR to support the infrastructure to deliver a rather specific area of research, translational research. That's to say early translational research and experimental medicine. In trials terminology, this is the sort of from first in human through phase 1 and into phase 2A. And it's that rather specific niche, really pulling from discovery science and in the earliest stages of clinical development. And I think it's really important just to keep that in mind. It's this sort of remit, as it were, sometimes gets pulled in different directions, even dare I say it, by people at NIHR. And I think there's sometimes a bit of confusion as to what actually the BRC is here to do. But I do think it's helpful for us to keep firm sight of that. And all of the activity that's supported by the BRC needs to have really direct line of sight to improve patient outcomes one way or the other. And I do think that's important. Just to briefly recap, the first iteration, as it were, of the BRCs came through in 2007, when a small handful of biomedical research centers were established at that point. And this is somewhat snowballed, funded by the NIHR since then, with 5 yearly competitions. We're actually just in the middle of a competition at the moment, expecting or hoping to hear any day now whether we've been successful or to what extent we've been successful in achieving support for the next 5 years of the cycle. The funding itself covers broadly 2 main areas, one of which is the research themes, which I'm going to just describe to you in just a moment. And the other is core research infrastructure that extends all the way across the campus. This is things like the clinical trials unit, trials pharmacy, tissue bank and brain bank are both funded by essentially by the BRC. A lot of IT infrastructure, not just for research, but we try and make sure that that's also delivering for CUH. And as you can imagine, these things are fairly closely aligned anyway. Cell phenotyping, there's a big biochemistry assay laboratory, the whole of the research office and the R&D office. So any research activity on campus here, that activity has to be the agreements for that, the contracts and so on, the feasibility assessments, they all come through the research office and indeed the Office for Translational Research. And I might just put in a brief pitch for anybody who's watching this, who's got a research idea, or maybe has got some ideas around intellectual property, who's wondering how they take that to the next step of translational commercialization. I've got this mantra of call Daphne. Daphne Kiravino in the R&D office has got an encyclopedic knowledge as to how to help you. So you can get her on the Adam Rooks email thing and just get hold of her, and she'll be able to advise you as to what the next thing to do is. So these were the research themes as configured in our last BRC iteration, arranged, as you can see, in a wheel around the outside, and within the middle at that stage, what were cross-cutting themes, imaging, inflammation and infection, immunotherapeutics, and then the constellation of different themes arrayed around the outside. Going to update that in just a mo, but one of the comments in the bibliometric analysis that was undertaken by the NIHR, independent bibliometric analysis, as part of the competition, identified, well, so it digs into the publications and impacts of each of the different universities and each of the different hospitals around the countries, and identified actually that CUH as a hospital, set aside from the university, scores first equal in terms of its impact, the impact of its research outputs compared to all of the other hospitals in the UK. And I think that's something we don't speak loudly enough and project loudly enough, is the real success of clinical colleagues here in the hospital and the work that they're doing. Also true to say that in the recent REF exercise on behalf of the University of Cambridge did, under Richard Gilbertson's leadership with the REF exercise, again scored phenomenally well. So real congratulations to them. Just a very brief plea for those of you involved in research. I know this sometimes sticks in your craw if you don't receive direct funding from the BRC, but nonetheless, as I pointed out, the BRC is kind of everywhere, underpinning all of our research activities, and it's massively helpful to our ongoing funding if you can just insert this little phrase in your acknowledgement section that the research was supported by the NIHR Cambridge Biomedical Research Centre. So thanks in advance to you for your help with that. I've already mentioned that the BRC is here to accelerate the steps from scientific discovery to improved health, really across diverse populations, not just within the Cambridge city limits, but across the whole of Eastern England, the country, and indeed globally. Of course, there are a number of rather distinctive Cambridge strengths: data science, genomics, experimental medicine, and really we want to use all of these techniques to understand what are the real early changes of disease, or the things that gives us an early insight as to the way things might develop, and to use this to help us to predict and prevent disease, or indeed in established disease to prevent the adverse consequences of that, to detect disease early and invent new treatment approaches, so diagnostics, biomarkers, new therapies, devices, the various different ways in which we can approach these problems to prevent those adverse outcomes developing. This is just a broad overview of the structure, but just makes the point that the BRC is well embedded within the governance structure of the hospital and the research board, chaired by Ashley Short, who I know is on the call at the moment, and answerable in turn to the trust board as well. So this is the new BRC. The point of this Circos diagram, it's a bit of a genetics plot, but it makes the point that each of our themes are thoroughly interlinked with the other themes across the BRC, and understandably that's something which the NIHR wants to see. Just to briefly highlight one or two points, and Richard and others may pick up on some of these, so I'm not going to labor this, but that some of the developments that have come out of our BRC in recent years truly do impact on the care of patients really across the country and around the world. So this is Antonis's CanRisk web tool, accessed by thousands of people every day to improve prediction and management of people at risk of ovarian and breast cancer. Sadaf Farooqi, many of you will know and will have worked with. Sadaf and I worked together when she was an SH when I was a registrar back in Oxford in the old days, but is an absolute world leader in really understanding some of the genetic contributory factors and the downstream functional consequence of those in terms of obesity, and then leading into new therapeutic approaches there. Gordon Smith's huge and very impressive POPs2 cohort, really understanding what are the drivers of adverse pregnancy outcomes and what we can do to mitigate those. Sharon Peacock, well known to everybody in Cambridge, and Vilas as well, of course, known to all of us clinicians as an ITU physician here. The work that they're doing, Sharon, of course, leading the COG UK initiatives impacting on SARS-CoV-2. Vilas with his TACMAN, basically asking simple questions, but bringing technology to bear and producing improved accuracy and quicker ways to make diagnosis in patients on ventilators on the intensive care ward. David Rowich, working with Shankar Balasubramanian and others, using Shankar's technology, really to help us to understand what is the actual impact of rare genetic variants and mutations in predisposing children to getting very sick, and showing just what a high proportion of these kids on either ITU or in the neurological clinics have high penetrance mutations, which once you know about them can impact on their clinical management. Martin Bennett in cardiology, patenting AI tools to help in the understanding of those at risk of heart attack and stroke. Rebecca Fitzgerald, I suspect Richard will talk about her developments in a minute. And Patrick in ophthalmology, using gene therapy to treat Leber's hereditary optic neuropathy. All of these things have come out of our BRC over the last 5 years. They're all impacting significantly on healthcare around the country. These are our theme leads over the next 5 years, hopefully, provided the NIHR funds us. They're a great bunch of people who work hard and rely on the support of our organization to help them to make their progress. So I'm sure you will be out there supporting them. And so briefly, before I hand over to Richard, just to highlight the fact that our Biomedical Research Centre really sits at the heart of the Cambridge life science ecosystem, and the hospital as well in many senses, often behind the curtains, as it were, not always immediately evident to people as to the fact that it's there and doing important stuff, but it very much is helping us to accelerate the translation of science into clinical tools, diagnostics, devices, monitoring, and new treatments. So I'm looking forward to hearing from respectively Richard, Charlotte, and Raj in a minute to hear their thoughts. And I'm going to hand over straight away to Richard, if that's okay. Richard, if you want to, let me stop sharing my screen and hand over to you. We'll do a Q&A session at the end if we get a few minutes there at that point, if that's okay. Richard, are you, can I just double check that is Richard still on online? Sorry, I've not got a list of the participants.
I can't actually see him on any longer.
Okay. Charlotte, can we move to you then? And we'll perhaps come back to Richard, who may be having some connection problems. I know he's in a hotel room in London, waiting to get back on a train, having been on an overnight flight back from the US. So Charlotte, over to you, and we'll bring Richard in just a moment.
Okay, so I was asked to talk about the experiences of embedding research into clinical care and lessons from the pandemic. So whilst the BRC is normally early phase translation and experimental medicine, all BRCs were redirected by the NIHR towards the national effort. And I thought I'd share a little bit about what we've learned and what we've done locally here during the pandemic that might be applicable to embedding research into clinical care for other things. So what are the benefits of doing research? Well, they're better outcomes for patients, and we know, and as was published in the NIHR's 10-year report, actually patients do better if they take part in research, whether they're in an interventional arm of a trial or the placebo arm, but they also have better outcomes if they're taking their treatment in hospitals that are more research active than less research active. So overall, if you are a patient and you want the best clinical outcome, being treated in a research active hospital and being in a research study means that you are more likely to have a good clinical outcome, whatever your illness, whether it's acute or chronic. But also there's improvement for healthcare systems from research. Actually, if we're going to discover the best care for patients and find value for money treatments, doing all of that requires research. And it's also a way to have a slightly more rewarding career. Over the last 2 years, as you will all no doubt know, we've had various peaks and troughs of admissions of hospitalised patients in the UK. And here you can see we have a peak in April of 2020, and then what felt like a never-ending peak in the winter of 2021. And things have been persistently increased with various ebbs and flows since last summer, although things possibly are levelling out a little bit at the moment. But this was a new disease for which we didn't really know very much, and for which we definitely didn't have any treatments. So it meant a huge amount of research was needed at speed, which is why a lot of the NIHR infrastructure, including the BRCs, were repurposed. And just to give you an idea of the speed of the repurposing that happened, the first case of COVID in the UK was identified on the 31st of January 2020. And then the clinical phenotyping study, ISARIC-4C, actually opened to recruitment on the 6th of February, so 7 days later, with the recovery trial starting on the 19th of March, and the critical care genetics study being repurposed to focus on COVID by the 2nd of April. This meant that by the 15th of May, we already had a clinical characterisation of 20,000 hospitalised patients admitted to the NHS, so that we knew what symptoms and what the presentations looked like, a little bit more about the clinical course of hospitalised patients in our setting. But by the end of June, we also knew that hydroxychloroquine did not improve the mortality of patients who were hospitalised with COVID. Dexamethasone did, and another oral antiviral therapy didn't. And so things continued, such that by the end of that year, actually, we had the genetic determinants of critical illness for COVID in more than 2,000 patients from the genomic study, and several more results. And I just sort of censored it March of 2021, so it just showed the first year of the predominant outcomes of most of the research studies. And you can see that actually we did a lot very quickly by diverting the research efforts towards COVID, but obviously this is not a long-term sustainable option. In total, more than 1 million people in the UK have taken part in NIHR-funded COVID research, and that was actually the case by the 13th of March 2021. So in 1 year, 1 million people took part in observational and interventional studies. And just to give you highlight some of the studies we've participated in Cambridge, the ISARIC-4C study in total has recruited more than 250,000 patients from across the NHS, and a substantial number here in Cambridge. The genomic study has recruited more than 18,879 subjects from almost every UK in the intensive care, every ICU in the United Kingdom, including ours. Recovery have recruited more than 45,000 patients in the UK. And of course, Sharon Peacock has led the world beating COVID-19 genomics consortium here from Cambridge too, which has led the way in virus surveillance and working out about the emergence of new variants. Just to give you some idea of the recruitment here, more than 250 of our ICU patients have been recruited into genomic. We've also recruited into REMAP-CAP, a critically ill study that's an interventional trial, as well as recovery in ICU and on the wards. And my own study, the HEAL COVID, which is the national post-acute COVID study, ADARIX has recruited more than 67 subjects into and is third nationally in the leader table. So what lessons have we learned? I think we've learned that when we repurpose all of the infrastructure towards one thing, we can do amazing things. But as I said, that came at a cost. And I'm sure Richard and others will highlight that actually there are patients with non-COVID disease who haven't had the degree of research opportunity over the last couple of years that they absolutely need. So we need to find a way to resource recruiting patients for acute illnesses that we may not have done previously, alongside resourcing all of the important conditions, including rare diseases, that we were researching previously. I think we've learned a few lessons about equipoise. Clinicians are a fairly opinionated bunch, myself included, no doubt. And we often think we know things that we don't. And I think if we've learned anything in the pandemic, we've learned that many of the things that we hold true may not be as true as we think they are. So, for example, in intensive care, many people were convinced that therapeutically anticoagulating critically ill adults with COVID was the right thing to do. However, randomized controlled trial data has shown that actually there's no benefit and a trend towards harm, whereas the patients we should be anticoagulating are those admitted to the ward rather than those admitted to critical care, and nobody thought that before. Similarly, dexamethasone, the majority of clinicians in the UK thought that this was potentially a bad idea at the beginning of the pandemic, and there were some fairly heated discussions about the idea of giving steroids to people with a viral pneumonia but it turns out that it has saved millions of lives across the world since the recovery trial produced their results in June of 2020. So I think us moving to understand that we don't know quite as much as we should do, and that perhaps equipoise is more often where we are with our ability to make evidence-based decisions. We should think about, are there ways in which we can randomise more patients into clinical trials as part of routine clinical care, because it will improve their outcome, just the sheer act of being part of a trial, but also we will learn more so that we can transform the care of patients going forwards. So I think thinking about how we resource the changing burden of research, a little bit of humility about our equipoise, and thinking if we can support by randomising patients in our routine clinical work, actually we will be able to transform the care of patients. And that was where I was going to stop.
Thank you, Charlotte. I think that's a really important thing for everybody to ponder on, actually, all of us as clinicians in CUH. The question about how we can embed research and trials activity as part of business as usual in our day-to-day management. And we'll perhaps pick that up in Q&A. We just had a message from Justin saying that Richard Gilbertson has had a catastrophic internet failure. I can't see him on the list as having resolved that yet. So if it's okay, we might move then to Raj. Raj, if you're okay to go next, and we'll pick up with Richard, hopefully, once he's restored contact.
Sure, of course.
Thank you.
So, afternoon, everyone. Thanks very much for the opportunity to talk. I'd just like to tell you a little story, basically, about a clinical study that I've been involved with. And I think it tells a salutary tale, building what Charlotte was talking about in terms of humility. But it also shows some of the ways in which you can leverage the support of the BRC, sometimes in ways that you thought of and sometimes in unexpected ways. So that's why I've sort of slightly flippantly called it Happiness is an AI Study, called Hamlet RT. So I'd like to start with an idea, okay? The idea is that we're not that good at predicting things in medicine. So this is a bit of data about the ability of different oncologists to predict survival of their patients with lung cancer. It's a little bit old now. It's quite interesting to look at the Kaplan-Meier survival curves, and also interesting to look at in terms of the early experience of the patients, which particular group were at greatest variance from the ground truth. Although I think that the consultant's predictive power did actually converge as we got to sort of longer and longer periods of time following it up. And I think people look at this sort of thing and we try and make objective predictions to guide personalized therapy and have to acknowledge that we're not good at it. So a lot of people think about, well, okay, how do we sort of build on that? And it's a big area in data science and machine learning. So if we turn that data into a concept that a data scientist would understand, and we replot that data on a receiver operating characteristic curve. So all we've done is to basically take that data and turn it into data about the sensitivity and the specificity of our observers and plot it onto a curve like this. And so a straight line basically is what I call the sort of coin flip line, or what my stats teacher used to call the hamburger line. And that means basically that unless you're north of that line, you're not really doing any better than tossing a coin. And so when we express that same data from that paper, we end up with an AUC ROC value that is, let's say, 0.55, 0.6, showing that perhaps we're not doing a lot better than a random coin flip. So we have this great idea. You talk to a data science colleague and think, let's build a predictive AI model that's going to do a lot better. Okay, and we take a whole load of clinical factors that we believe to be important. They reflect our existing prejudices, as Charlotte was saying. And then we use, let's say, for example, not deep learning, but a very, very simple set of machine learning models based on regression analysis, mainly linear sorts of transformation of the data when we're looking at predicting survival. And we build a whole bunch of those together. So we have different rules that factor in different data, elements of data, and then they vote together and then build a prediction, basically. So if we build a model like that, this technique is very dependent on data. So we have a data set, it's been curated within our BRC, And what we know is that we need to split that data set into a group of patients that the model is trained on and a group of patients that the model is tested on. And what we do is we first go through a training exercise, and we have some function, basically a loss function, that shows how well the model starts out at being able to do these predictions against our observations. And basically, as we let the model go and train on data, we see that basically over time, that score actually starts to come down towards 0 to show that the model is doing an increasingly good job at simulating the outputs. Then, of course, we switch over to another set of data, the validation data, and we rerun the model against that data and say, okay, well, how well did you do on a group of patients that you didn't actually train on? And we seem to get really quite good results in the training and validation model. We start patting ourselves on the back, and we end up with a receiver operator characteristic curve that looks a bit like this orange one rather than the blue one. And we kind of think, okay, well, we get very, very impressive performance. But if you're in machine learning, you probably have a sense that you do not want to see an output like that, because an output like that is likely to be too good to be true. Because a truism of machine learning algorithms is that they are extremely good at overfitting the data that you train them on. So it is no surprise that a model would actually produce such a good fit. But of course, what it won't do is to reproduce those good results on another set of patients from somewhere else. So a real example, okay, so we're interested in predicting toxicity from radiotherapy. This is a group of patients that we collected prospectively over 5 years, head and neck cancer. We did everything by the book. We collected a very large set of clinical and imaging observations, and we were determined to make sure that this model did not overfit. Okay, so there are various statistical techniques that we can use. We can look at the discrimination performance of the data that we put into the model and actually say, okay, well, between those group of patients that got the bad toxicity outcome and those that didn't, is there actually a reasonable difference or not? And then if we look at the different predictions that we have of different toxicity, can we actually observe that we've got a good spread of these different things that we're asking the model to predict before we actually build this fancy machine learning model? So we did all of that, and we thought we'd do really well. And guess what? Once again, the machine learning model spectacularly overfitted our data. So we ended up with a model that could predict head and neck toxicity in effectively Caucasian men from East Anglia and not much else. So the question is, if you want to be happy with the model that you create, you want to take steps to avoid your model from overfitting. And this is where you need to go start talking to people. And some interesting things are observed. The first thing is that it's much less likely that a model will overfit if your endpoints are clinician reported rather than patient reported. Charlotte mentioned clinician reported outcomes often bring our inherent biases. Also, clinicians, we tend to use limited elements of the scale, given a sort of, a spectrum of possible reported outcomes, whereas patients will often use a wider scale. And so what we did when we redesigned the study was to actually talk to patients and say, okay, well, let's think about building a patient-reported outcome measure that you can run electronically on your device, and actually think about how we're going to do this and how we're going to build this particular instrument to be as discriminant as possible. So we involved colleagues that we've worked with extensively within our PPI engagement team in the BRC. Amanda Stranks got involved as well, and it was tremendous to look at both the design of the model, but also to step back a bit and understand patients' perspective about doing this at all, about building predictions in machine learning. The next thing that we did was to use the power of our BRC to go bigger. I was determined not to build a model that would overfit to East Anglian patients. So within our BRC, which is very well respected for all the reasons Miles explained, plus another one, which is that we're very collaborative in our BRC, I went through an organization called the Oncology Translational Research Collaboration, which is basically a focus of all of the BRCs that are interested in cancer themes. And we come together and discuss collaboration projects, low-hanging fruit, common interest, and common projects that we can set up effectively. And so through the power basically of the BRC and this collaboration thing, it was fairly easy for me, even during COVID, to sort of open up to 8 sites at the moment. We've got another 2 that are just going to be stood up in the next couple of months. Despite the study opening during COVID, still managed to recruit 350 patients, which makes us the largest recruiting radiotherapy study in our network and in the country. And we've got over 7,500 scans so far, and we're aiming to get to 2,000 by the time that the project closes. But more importantly, we get that extra diversity of the patients, their ethnicity, their socioeconomic factors, and that diversity of reporting effectively that comes in from those patient-reported outcome measures, which is likely to improve our ability of our model to kind of consider the different patient groups and make it less likely to overfit. Miles talked a lot about building infrastructure in the BRC, and I love that when it comes to anything related to IT. So I've kept it really simple. But one thing that we did was to federate our data instead of ingesting it and bringing it all into one large repository, preferably held in a Cambridge building. So the idea that we have of federation, data federation can mean different things to different people, but I'm talking specifically here about the train and track model. So what we did was that each center, including ours, had a data store into which that data is parked, and we use appropriate data processing tools to make sure that can be done in a safe way. So as the study goes on, these data stores accrue data, imaging and non-imaging data from each of the centers. Okay, we can of course combine them at the end of the study to answer our primary endpoint, but along the way, what we can do is we can lay down track temporarily that connects these data stores, so that a researcher who's got a really good idea for a prediction model that perhaps we didn't think of from any of the centers, in fact, can actually run his model on the track. He or she doesn't get to see any data. The only result that goes back basically is the model output file. And then when we're done, we clear up and we take away the track. That's the kind of concept basically. And so I think that all of these techniques are the sorts of thing that when we come to BRC4, we'll be really good at actually making sure that we get more bang for buck when we're starting to do any kind of predictive radiomics, precision medicine, integrative cancer medicine, whatever you call it. It all boils down to building the best regression models you really can at the end of the day. So that's not where the story finishes, although I'm very happy with where it's gone so far. Something else interesting happened, which is that when you have a platform like that for collecting really, really good clinical endpoints and multidimensional patient data, people start to come and talk to you and they say, well, that's quite interesting. So a group of people who are interested in looking at circulating tumor DNA, so finding out whether shed fragments in the blood of tumor can make a prediction for therapy response. And radiotherapy is particularly good for that because obviously it's given at multiple time points over a prolonged period of time. So we had this idea of speaking to Nitzan Rosenfeld, who's got these amazing digital PCR techniques. So instead of having to collect blood specifically, hold blood into special tubes and spin it down and store it very quickly at point of care, which is a real limiter to circulating tumor DNA research for minimum disease detection, could we effectively use a finger prick of this blood and store it onto a card for dried blood spot analysis, a bit like we use for metabolic conditions when we're screening neonates? And when we had that, we also spoke to people who are interested in senescence research, who said, well, look, if we're going to collect those blood samples over multiple time points over an intervention that is both spatially and temporally directed, i.e. radiotherapy, it'd be really interesting to look at senescence response and the immune response to tumor cell death at the same time. And so effectively, we were able to put together this sub-study, which is highly translational, on the back of a study that's actually just a pure AI study. So that was a joy to behold that. And when we were building this again, we went back to the BRC to speak to our patient representatives to understand how we're going to build this expansion to the study. What could we ask for? What couldn't we ask for? And we were determined, I thought, again, my prejudice is there's no way we can ask for permission to do germline gene sequencing. We should surely just ask for permission to analyze known tumor libraries, shouldn't we? In terms of when we're asking patients what we can do with their whole blood samples. And the answer that came back from our BIC PPI group was, don't waste any of the blood. I mean, if you need these analyses and you think they're going to be useful downstream to answer your primary endpoint for the study, then collect them and tell people that you're going to collect them. Don't weaken your primary endpoint analysis for fear of what you think patients won't let you do. So again, just really interesting, the power of putting patients right in the middle of the design step. So when Ashley sent out the title for this evening's thing, it was Cambridge BRC helping doctors to help patients through translational research. I rather flippantly reversed the doctors and the patients, because my little experience tells a story where we can take BRC infrastructure that enables doctors to ask interesting questions, but then get patients to refine the questions and the implementation, and then do the research to hopefully generate some answers. So I'll stop there. Lots of people to thank. And just as I said, if you remember the adverts from the 70s, happiness is a cigar called Hamlet. That's actually got nothing to do with my study, but I just thought it would grab your attention. Thanks very much.
Thanks, Raj. That's great. And in many senses leaves us in a really helpful place, which is with patients at the center of the research that we're doing and helping us to frame the research questions that we're asking. Sadly, Richard Gilbertson's internet has completely crashed. He's at the Institute for Child Health at the moment, and apparently their entire internet has gone down. And so, unfortunately, we're not going to be able to hear Richard Gilbertson's talk this evening. So apologies about that. Nonetheless, I think from both Charlotte and Raj, we've heard two thought-provoking talks coming at the world from arguably slightly different, or significantly different perspectives. But I think, you know, it gives you, I think, a bit of a flavor of my life over the last 2 years. It's like every day is a school trip for me, hearing about this amazing work and research that's going on across the BRC, you know, across our currently 16 or 17 themes, and the really, really cool stuff that's going on. Not just within the BRC, but I'm also acutely mindful of the other really good research that's going on across CUH. And one of the questions that I wanted to ask as I came into the post was, how can we better support our clinical colleagues with their research ambitions as well? If you've got interests in that direction, you want to talk to me about it, then please do come and let me know, because I know it is a frustration as to how we can better do that. We do need to bear in mind that, of course, we don't have a certain amount of money to be able to point at these things, but nonetheless, for people doing translational research with a direct line of sight to improve patient outcomes, we're keen to support them. Are there any questions that people want to ask? And if there are, I don't know whether you want to put them in the chat or who is monitoring the chat, but it would be great to hear different people's perspectives. We've heard about, you know, data science and IT and some of the IT infrastructure. We've heard about involving clinicians in recruiting patients to clinical trials as part of business as usual. One of my own concerns relates to, you know, the impact, the ongoing impact really of COVID, and how we as a hospital have responded to that in terms of our ability to recruit, for example, in the outpatient clinic. It's much more difficult to recruit people when you're talking to them on the telephone or on the video than it is if you've got them talking to you face to face. And I think us walking through those consequences and how we can best mitigate those, they're all really live questions. And I'm sure other people on this call have probably got their own views as to how those things might play out, or approaches that we can bring to bear. Sharon, I understand that you've got your hand up. Sorry, I've not been very good or diligent at this. Sharon, question, please.
I do. Thank you so much. Thank you. Well, as you know, I sit on the board, and at the moment there's a lot of discussion about the, you know, the South Integrated Care Partnership, and what that really means for the hospital. And as I sort of listen to your plans and thinking about kind of involvement of patients with doctors and so on, and also appreciating that there's huge health inequalities across our patch, I just wonder, as you know, the lead for the BRC, what you're thinking about now when you hear about plans for you know, the Integrated Care Partnership. I know it's some way off down the line, but this looks to me as if it represents a massive opportunity for research that extends into the community more than you're able to do. So I'd be really interested, Miles, to hear what you think about the opportunities that this presents to you.
Yes, thanks, Sharon. And as you know, we thought long and hard about this as part of our BRC application, and it is a really key priority for us in Cambridge and in the BRC to think how best we can use the resources and skills that there are available to us in our research community to address this fundamentally important problem of health inequality. I think there are a number of different routes into this, and I really hope that the ambition that the ICS, has for its own delivery is something that we can support them with and bring to bear fruit. To my mind, I think I'm a big believer in data science and the power of data science, but we need to use this technology wisely. I think we've all seen how this can be subverted and go a bit, not so much wrong, but just not deliver on its potential and on its promise. And so I think we're in much better shape now, because I think people have a much better understanding as to what the potential pitfalls are here. But I really want to see us as a BRC connecting to the people that we can connect with in the university and in the HDR, the Health Data Research UK environment, and other big and powerful players in this field, really supporting the ICS to help them to understand what the issues are. Where is the health inequality? There are already great tools out there, as you well know as a public health doctor. There are already great tools out there for understanding health inequality. And what we really want to do, I think, is to line up what can we use routinely collected healthcare data to help us to understand why those health inequalities exist, and what are the interventions that really make a difference to that and mitigate those unequal impacts geographically, by ethnicity, by socioeconomic background, and so on and so forth. Of course, diversity comes in many different ways across our region as well. But I think keeping our eye firmly on use cases and ensuring that we stick with things where we have some sort of a handle on what we're trying to achieve, rather than going at this with a sort of, oh, let's boil the ocean, let's try and reinvent some grand IT infrastructure that can do everything for everybody. We've tried that before. We know that doesn't work. To my mind, let's work with people like James Rowe in neurodegeneration. Let's work with Sadaf in obesity. Let's work with the people who really have got quite focused questions, have already got established contacts in the research communities and indeed in the patient communities in which they operate, with Nick Ware and with Nita Farui, others who've really worked hard to make these points of contact. And let's build outwards from their own areas of interest and expertise into these really important research questions. Let's try and use the opportunities that we have to link up the data science to help support them in the work that they want to do. Mary Dixon Woods with the Discovery program, and there are lots of different parts of the jigsaw that we can help put together, but we need to keep it focused on health outcomes and benefits, not to allow this to get somehow subverted into a big massive IT spend or a big scientific foray, but which doesn't quite have impact or line of sight to improve patient outcomes. I hope I haven't waffled on too much, but I do believe that this is important. And a lot of it is about communication, actually. As you well know, you're a brilliant communicator, but it's about making sure that we're still talking to all the vested stakeholders in this, and that we don't sort of disappear into our own laboratories or disappear into our own specialty areas. Being a gastroenterologist, I know said something else there, but we need to make sure that we're all talking to everybody, and that the IT infrastructure that we're developing here on campus does exactly what Raj says, federates and talks to itself. Raj, do you have thoughts about this as well? I know you know much more about this sort of data science area than I do, and there are others indeed on this group who on the call at the moment who have much better understanding of this.
Yeah, well, I think as you said, it's simply not expecting the data to elucidate the answers in and of itself, and making sure that there's appropriate knowledge and understanding around it. From my point of view, I think that's where we excel effectively. We're bringing the BRC's resources. There's a move away from these sort of waterfall design sort of things for building these large integrative medicine analyses, and doing it more in a sort of iterative way, where you look at data, you put some analysis in, you put in your priors, and then you go look at it again and again and again.
We've got Victoria Keeval on the call. Victoria, sorry to put you on the spot, but I know you've got good experience of this.
I could feel it coming, Miles.
So well done.
I had my finger ready on the camera. Just hearing you all talking, I was just thinking the one danger with trying to reach those people who are the least well off or the most deprived, they're the least likely to even be represented in our routinely collected healthcare data in a way that's accessible. And what you don't want to build is some kind of AI algorithm or tool that's actually exacerbating current inequalities because of the representation. So that would be one thing I would think is a really big challenge. Not every hospital has been able to invest in the same way that we have in our EPIC system, and also in the resources to then actually retrieve that. So that was just one of the thoughts I was thinking when you're talking particularly about health inequalities and what we can do to address that.
I share that concern, but at the same time, I think it's important that we don't fail to do anything out of fear of exacerbating a digital divide. And, you know, I think you understand this area much better than I do, but it is so complex that we could spend the next 5 years trying to work out what the right thing to do is without actually doing anything. And that, of course, would be wrong as well. And at some point, I think we have to take a view on what is achievable, where do we start with this, how can we then build that outwards? But I think as long as we're all honest with ourselves, recognizing the importance of getting underneath health inequalities and recognizing that that's an important priority for us, then let's not delay starting for fear of this.
Yeah, and so reaching out to some of the applied research collaborations that have their sort of more vulnerable populations in focus that they deal with, to work out how to access that data and how to include those populations in the tools that are being developed.
And indeed talking to other people in other BRCs, and Raj mentioned the TRCs that are doing this, but you know, I'm lucky to sit on the BRC directors calls, which we have once every few months, and we hear lots of great examples of stuff that other people are doing, networks of nursing homes that have been assembled around KCL down in London, for example, and others that are really pushing the boat out on this. And again, you know, we need to recognize Cambridge is great for many things, but we're not the experts in absolutely everything, and others out there have got fantastic ideas that we need to all build on. And that is part of the excitement of NIHR, and Charlotte would speak eloquently to this, I know. Charlotte, do you have thoughts about this?
I was just going to talk and say a little bit about Standing Together, which is an NHS digital funded national collaboration to improve the inclusivity of data sets for AI and other data analysis things that actually we are taking part in. BRC and investigators there who work with the regulators about AI particular tools. But yeah, we are taking part in that collaborative because there's a recognition that actually the data sets for which many of the AI tools are built on are not inclusive. And so we're contributing data and part leadership towards that. So I think those kind of initiatives will come over the next 12 months.
Thanks, Charlotte. Can I just pitch a question to, since this is a sort of BRC focused call, and I've already articulated the concern or the issue that lack of patients coming through our system may present to us. Ashley and John, can I put you on the spot a little bit just to hear John Firth, can I understand your thoughts about this and the potential impact that this has, and whether the Trust recognises this, the importance of us trying to get some restoration of patients coming through our system and coming to see us face to face. What's recognizing that there are big advances that have been made through the pandemic, and we don't have to do this all the time, but that we seem to not have regained our equilibrium yet.
Thanks, Miles. I wasn't expecting to talk tonight, but thank you. So I think you know, there are two things on there. There's been a huge benefit to a lot of patients in not having to take a whole day off work when they may not be paid. You know, if we come back to the inequalities, if I take a day off work to go to a medical appointment and they may not all be as efficient as your clinic, sometimes that could cost a whole day, particularly if I've had to come all the way from Norfolk or many of the places people come to see people at CUH. And as I say, if you're paid by the day or on a 0 hours contract, that could have cost you quite a significant amount of money. And we see patients who are making the decision between coming to a medical appointment and eating or heating. So I think, you know, it comes back to Victoria's points. We need to find ways to reach into people's lives, but we need to find innovative ways to be able to recruit people into research without actually making them having to come all the way up to the hospital. And we've talked about this before. We need to understand people's lives. We need to understand how we can access that, and we need to to work out how we use the technology, you know, this fabulous technology, how we can use that to innovate in recruiting these individuals into research programs, and so that we can really understand everybody in our community. I don't think the answer is bringing everybody back to outpatients. I think that would be a retrograde step. I think the next step is how we figure out how to make the most of what we have got and build on that.
Yeah, my own view is probably that there's more of a balance that we need. I totally share your view that we don't need to bring everybody back all the time, but we need to, well, certainly in the world of gastro, need to bring more people back than we do at the moment. And I think some of those things will help us to do lots of things, but significantly importantly, including research. Now, I'm mindful the time is running out. So has anybody got any other questions that they want to ask before we wrap up and I hand back to Justin? I can't see any other hands up. So that being the case, can I just say thank you to everybody for joining us this evening. Thank you to Charlotte and Raj in particular. I'm sorry we didn't get to hear from Richard Gilbertson about the amazing work that's ongoing in our cancer theme here on campus. But we'll catch up with that another time, hopefully. And Justin, I'll hand back to you now, if that's okay.
Thank you, Miles, Charlotte and Raj, very much indeed for your time. What I'll probably ask Richard is whether he might be willing to record his talk, and I'll send that separately along with a recording of this. So watch out for that in the days to come, and see if we can incorporate that nonetheless in absentia, as it were, as part of the recording. So again, thanks all. We'll make a close there, and probably now have a break for a month or two over the summer from the Consultant Forum meetings. I'll look forward to getting some new dates and topics after a summer break. So I'll circulate the recordings very soon, and hopefully have Richard's in amongst that. Thanks everybody. Have a good evening.
Bye.